Hi everyone, Dr. Jana Valine here again with Intuition Health. Again, just waiting out a little bit of rain while I'm on my walk. And so I thought of another story as we were sharing, but just kind of the funny things that sometimes patients come in with, what they hear, and kind of that game of telephone of what they end up coming in with. And so I had a patient who was in with shoulder pain. Remember, I'm a sports medicine physician, so there's, I don't do orifices anymore, right? Like there's like kind of this from here to here of like where I don't really do that. And so she's in shoulder pain, and it tells me that she thinks she has a torn labia. And so I, of course, inappropriately start laughing and just like, what? And so again, it ended up being okay when I explained to her why I was laughing. And I was like, nope, not your labia, it's your labrum. And so I was like, if you tore your labia, you're with the wrong person. I might be family practice, but I ain't doing that down there no more. And so we talked about the labrum, and the labrum in the shoulder is this ring of cartilage that lives around the socket part of the ball and socket joint. And so you have cartilage that lines into the bones, and then you have this thicker cartilage called the labrum in both your shoulder and hip and these ball and socket joints that protect the joint. And so labral tears, not labia tears, that's again a completely different person that you want to be seeing. These labral tears, if you're really young overhead athletes, sometimes those need to be fixed, but most of the time, again, they're part of an underlying problem. Usually people have some tendinopathy or partial tear starting the rotator cuff, maybe some laxity of the ligaments, maybe an old trauma. So these labral tears are usually signs of kind of the complex of the shoulder of something going on. So like we talked about in the back, it's a functional unit. The shoulder is also a functional unit. So when we look at that, usually a labral tear, especially for over the age of 25 or 30, it's not an isolated problem. And so going in and just fixing that, a lot of times might not fix the problem for a lot of patients. They might still have pain, or further downstream, they have other problems because, again, that was just a piece of it. And so when we look at using things like prolotherapy, perioneural injection therapy, PRP, we're trying to treat this structure as a whole functional unit. And the history, the exam, you have to use all of these different techniques. Ultrasound, X-ray and MRI can be helpful as well, again, but we're not treating the image, we're treating the patient in front of us and figuring out, well, what can they not do? What are they trying to get back to? And we're treating that structure as a whole. So we're looking at multiple different areas that might need to be treated for a better long-term outcome. Again, if you have any other funny stories or things you want to share, please comment below. Thanks.